So our next speaker is Dr. Ferrell, Betty Ferrell. She is a nurse for many years, and her expertise is in palliative care, focused on pain management, quality of life, and she is the director of the Division of Nursing Research and Education and a professor at City of Hope National Medical Center here in Duarte, California. She's a fellow of the American Academy of Nursing and published quite a bit and has collaborated with Christina Pukalski. Welcome, Dr. Ferrell.
Good morning, everyone. It's wonderful to be here with you and to be a part of such a thoughtful program and so many wonderful ideas. And what I would like to do today is just to contribute my little piece based on my work over the last 40 plus years as a nurse, primarily in the areas of hospice and palliative care. And so what I'm going to do is to talk with you about the nature of suffering, this concept of suffering, and from the perspective of the goals of nursing. I'll be sharing some work that I did with my colleague Nessa Coyle, who is at Memorial Sloan Kettering in New York City, and a book that we wrote together on the nature of suffering and the goals of nursing. So what I would like to do is to start by sharing a story with you. And so I'd like maybe everyone, this would be a good time to just take a really nice deep breath and sort of relax and be here for the moment. And while I read just a short story to you. In a medical surgical unit in a small Midwestern hospital, a patient's suffering is reduced by the night shift nurse. The elderly woman has lung cancer. She was admitted 2 days ago with a bowel obstruction, likely the cumulative result of immobility, inadequate food and fluids, medication side effects, and her progressive disease. Her uncontrollable nausea and vomiting and pain over the last few days at home are now relieved by an NG tube, IV fluids, and careful titration of analgesics. Having finally slept a few hours, the woman awakens in the middle of the night. Given the myriad of tubes and wires attached to her body, she remains motionless, afraid to move. And yet her wakefulness stirs her exhausted daughter, who's wedged into a reclining chair at her bedside. The mother and daughter exchange mutual queries. "Are you okay? Why don't you go home?" the mother suggests. "Oh, this chair is fine," the daughter lies. The woman's husband went home after a few hours at the hospital. After 55 years of marriage, the angst of seeing his wife so miserably ill and the strangeness of the hospital world were enough to propel him home, despite the silence and loneliness of an empty house. Mother and daughter reaffirm to each other that he's home asleep, but both know he's probably wide awake, sitting in his easy chair in the living room, sipping stale coffee, reading his Bible, counting on God to come through. After all, God has come through many times before. He has faith. God will come through again. The night nurse enters the room, careful not to turn on the bright lights, even though she sees that both mother and daughter are awake. She performs the routine checks. The NG tube is functioning, the IV's dripping, the urinary catheter's draining. The same nurse was on duty when the woman was admitted the night before. Comparing her patient's distress then and her current relatively peaceful state, and given the goals of care, she decides to skip the routine vital signs. Instead, she asks the woman how she's doing. The patient politely answers, "Fine." She adds that she really didn't even know how sick she was until she started to feel better. The nurse then resists the urge to hurry out the door to the next patient and continue her long list of tasks. But it's hard to stand still. She sees the woman's cachectic body. She hears the flow of oxygen and the pulsing suction of the NG tube, and she feels the clammy coolness of the woman's arm as she gently touches it. This nurse knows well the signs of approaching death. Too well. Death is a frequent visitor here in this hospital. Assured of her patient's comfort, the nurse speaks to the daughter. "You must be relieved that your mother is not in pain now." The nurse says how wonderful it is that the daughter has been able to be here and acknowledges the daughter's exhaustion. As the daughter's eyes fill with tears, she finds herself grateful that the room is dark. In just 2 days, she will need to leave to pack her own daughter off for college. On the airplane, she will reverse roles. She will become the mother and somehow navigate this other and almost as difficult life transition. After the move to college is completed, her husband will drop her off at the closest airport so she can return to her mother. She's been praying a lot too. She asked God, whose idea is it that she could lose her mother and her daughter in the same week? Her faith is usually strong, but not this week. She's found her limit. The nurse senses the quiet tears of the daughter hidden from her mother's eyes as she lies next to her, staring at the dark ceiling. She asks the daughter if she would like some coffee, but it's the mother who answers and says, "We are tea sippers." She describes how the two of them have had tea parties all their lives. From the time the daughter was a little girl with a floral porcelain tea set to the current heartier mugs shared over monumental life decisions, these two have sipped tea. The pale and weak patient perks up and proclaims, "You know, we could have a tea party now." The nurse hesitates. The woman is NPO, indicating she can't have oral fluids due to the bowel obstruction. But given that the primary goal for her patient is comfort, and given the enormous pleasure this ritual would give them, the nurse decides to let her have a few sips of tea. The NG suction will keep the sips from becoming instant violent nausea. In silence, all three women realize, with profound grief, that this tea party may well be their last. The nurse excuses herself and goes to her locker to get her special stash tea bags. No industrial hospital tea bag will do, not for this occasion. She returns in a moment, a full cup for the daughter, another smaller cup and a straw for the patient. There is a deliberate pause, then an intimate connection as the nurse's hand touches the daughter's hand and lingers as she offers the tea. She leaves only when she is certain her patient is comfortable, careful to leave the lights off and to close the door quietly. The mother and daughter sip tea. In the stillness of the room, with only the intermittent sound of the suction machine, they are the recipients of the sacred care of a nurse. That story is my story. It's the story when I was a daughter, and that is the story of the death of my mother. And my mother died 21 years ago, and yet I am reminded every day about the kindness of a nurse, the sacred moment when the nurse realized that it was time for the last tea party. And that is the memory that I hold now, 21 years later. And that is really the essence of my message today. What is the nature of suffering, and what are the goals of all of us, whether we be social worker, chaplain, nurse, physician, volunteer, music therapist, physical therapist, that we all exist in this world of healthcare to relieve suffering. And so what do we know about suffering? What can we say about suffering, and what can we teach each other about suffering? I want to talk a bit about some previous literature, explore some narratives, and share with you some additional stories of patients that have been a part of my life and my work, and then to share with you sort of 10 tenets about the nature of suffering. Many, many years ago, when I was first learning about this concept of suffering, I came across an article in, a big stack of papers I was reading. But when I came to this particular paper, literally, I felt like my life stood still. It was written by an ethicist whose name was William Reich. And as I read this paper, I was a early nurse, and I was spending a lot of my time dealing with patients in severe pain. And what William Reich, this ethicist, wrote in this paper was, quote, "Those who scream in pain and suffer in silence." And those words took my breath away, because I could remember so many times when a patient had rang their call bell and said, I need a nurse, I need my medicine. And yet when I walked into the room or to the home of this patient in pain, I suddenly had this realization that there was no amount of morphine that was going to help the pain that this person was experiencing. Because what I was witnessing was deep suffering, the kind of deep suffering that is not just going to go away because of a dose of medication. And what William Reich said is that when we are willing to be fully present, when we are willing to go to grab the next dose of medicine, but rather to sit with the person who is in pain and suffering and listen to their pain, when we are willing to be there, not to fix, but to really accompany people through illness, that is when suffering is relieved. And so what William Reich said is that you and I come to the bedside. We come to people who are very ill, who are in mute suffering, meaning they can't express their suffering. And yet, when we are willing to listen to them, to be with them, and they're able to express, when that nurse was able to hear the suffering of what it was like for a daughter to sit at 3 a.m. with her mother who was dying. When we are able to help people express their suffering, what happens is what he refers to as a new identity. The patient is transformed. And what I would share is, and we are transformed, right? When you are there for those moments, you cannot be unchanged. And so, this leads us to say that whereas so often in our culture and society now we separate the scientific, from the sacred, the scientific from the spiritual, our task is really today to say, how do we bring these worlds together? How do the spiritual and the scientific come together? One of the wonderful writers in this area is a man who is both a priest and a physician, Dr. Semel. And he wrote a wonderful book called Rebirth of the Clinic. And these are his words in the book. He said, under this new medical covenant, a spiritual scientific practitioner would affirm that the transcendent is made manifest at the edge of the surgeon's knife, at the tips of the palpating fingers of the pediatrician, in the firm handshake of the internist, in the birth of the child whose unwed mother has AIDS, in the tears of the woman who feels a hard lump in her one remaining breast, and in the vacant stare of the elderly man with dementia. A spiritual scientific practitioner would affirm that the transcendent is there when disease and suffering are recognized together, when the hand that performs the spinal tap distills compassion into the needle's point, the objectivity of science with the subjectivity of God's healing will, the particularity of the case at hand with the universality of a profession under oath, the finitude of the moment and the infinity of a life lived in the service of love. Thus might the clinic be reborn. Right? I love this because I read this book in the early stages where everyone was talking about reform of healthcare, right? And every time I read his words, I think, this is what reform of healthcare looks like, right? We can shuffle who pays for what, right? We can shuffle who's inpatient, who's outpatient. But the true reform of healthcare happens when spiritual scientific practitioners care for people who are seriously ill. So throughout my career, I've done a lot of research with people who are seriously ill, and most all of my work is guided by a model of quality of life. And the model of quality of life basically says that for every person is a spiritual person. Some of our patients happen to be religious, but all people are spiritual beings. And so we think about quality of life as being physical, psychological, social, and spiritual. So for many years, I had done a series of pain studies where I looked at people with pain, and we talked about, so someone has a problem of pain, but we talked about the whole person, the whole human being. And so we examined physical issues, physical aspects of pain, but we also examined psychological and social and spiritual. So after doing pain studies for quite a while, my colleagues and I were about to do a study on the problem of fatigue, as there was more and more work around the profound experience, the big problem of fatigue. So I was about to start this study, and one of my colleagues who was a little skeptical of most of what we were doing said, "Please, Betty, just tell me you are not going to try to use that quality of life model to look at fatigue, right? It's fatigue. People get tired. Don't make too much of it, right?" And so, of course, I'm like the 5-year-old. You know, all you have to do is tell me to not do something, and I was set to do it. And so I said, okay, let's redesign the fatigue study. And so now, when we go to the bedside, instead of just asking people about their fatigue, what they can't do, let's ask people about their fatigue, but then let's ask people, how does fatigue affect them, not only physically, but psychologically and socially and spiritually? So the very first patient I went to talk to was a 40-year-old woman who was newly diagnosed with ovarian cancer. And so I went to her and I said, "Can you tell me about your fatigue?" And the woman looked at me and said, 2 weeks ago, I was a healthy soccer mom. I have 2 young boys, committed to, seeing them grown. I'm a wife. I own a business. I work. I am the caretaker for my 2 aging parents. That was my life 2 weeks ago. And then 2 weeks ago, I was diagnosed with ovarian cancer. And then she got really quiet, and she looked to me, I think really wanting to know, do you really want to know about fatigue? And she said to me, "My fatigue? I get out of this bed in the morning, I walk across the room, and I brush my teeth, and I am so exhausted, I have to go back to my bed." And then she looked right at me and said, "Fatigue wastes my time, and my time is precious." There it was, right? When we take the time to approach people, understanding their suffering, understanding that the problem of fatigue is not just about how tired you are, but the problem of fatigue is about what fatigue is doing to what matters to you most, then we begin to hear the suffering of the people that we serve. So Eric Cassell is a physician who you've probably heard or know about his work, who wrote The Nature of Suffering and the Goals of Medicine. And what Eric Cassell said is that suffering experienced by persons, not merely by bodies, and has its source in challenges that threaten the intactness of the person as a complex social and psychologic entity. The next story that I want to share with you is a story that I call The Face of God. Robert Rodriguez is a 72-year-old homeless man living in San Diego, California. Having immigrated from Mexico 3 years ago, he came to a community clinic seeking relief from continuous pain, nausea, and diarrhea associated with advancing pancreatic cancer. He came to California as he was showing signs of dementia at the urging of his son, who was a dock worker in a shipyard. But shortly after Roberto arrived, his son was killed in an accident. Roberto is a quiet, stoic man who graciously accepts any relief the clinic can provide. Over the last 4 months, he has been seen regularly by James, a clinic nurse. Roberto is self-conscious of his appearance, his social situation as a homeless man, and his increasing reliance on the clinic as his body declines. In recent visits, Roberto has started to express his suffering to James as he speaks of his elderly mother left behind in Mexico, the wife he abandoned a year ago at the height of his alcoholism, the painful loss of his son, and his worsening symptoms. James has worked diligently with the clinic social worker to maximize all possible care for Roberto. He refers to the patient always as Mr. Rodriguez and acknowledges his kindness to the other clinic patients and willingness to wait so sicker patients can be seen first. James has encouraged Roberto to take his pain medication, assuring him that his use of morphine is not addiction. And today, James discreetly provided Roberto with adult diapers to wear when his diarrhea becomes extreme. James's goal is to see Roberto placed in a long-term care setting for what likely will be only a few weeks to months of remaining life. He and the clinic staff are desperately working to achieve placement amidst a bureaucratic, overburdened, inefficient county health system that has lost the request and seems unlikely to respond. James's hope is that Roberto will not die alone and that his symptoms will be relieved. This week, James arranged for a volunteer Catholic chaplain to be present at the same time of Roberto's visit, and he orchestrated a private encounter in a clinic room while Roberto awaited the physician visit. Roberto tells the chaplain that James has been the face of God, and that if it were not for James, he would not come to the clinic. Roberto asks the chaplain for one favor. When he is no longer coming to the clinic, could the chaplain give James a tarnished metal cross he carries in his pocket? Again, a beautiful example of suffering relieved. There were some wonderful nurses who way back many years ago began to explore this notion of what it means to witness suffering, David Kahn and Rick Steves. And they wrote about our role as witness and moral agent. And what they said is that we who work in healthcare have this sacred work to do. We have this privileged work to do because we are able to be the first-hand observers, to provide voice. And so just in the case that you just heard about, James the nurse was the first-hand observer of Roberto's experience. And James was able to provide voice to help connect Roberto with the things that were most important. They wrote about having ceremonial roles and rituals, so whether it is a sacred bath, whether it is an encounter with a volunteer chaplain, and that we are the expert witness. But most important, what they write about is that because we witness suffering and don't turn away from it, we are then in the position where we can speak of it. We can be advocates for social change to make care that is more receptive to the suffering that people endure. The next example is a patient, Mr. Farber, a case of the heart. Mr. Farber is a 60-year-old Jewish man who, with his young family, moved from Israel to America 30 years ago. He was first a bookkeeper, and after many years of evening classes, he became an accountant. He's worked hard to provide for his wife and 5 children. His wife is diabetic and has had many physical complications over the years. Mr. Farber is a loving husband and has nurtured his children, their spouses, his grandchildren. 4 months ago, he was diagnosed with heart failure. And 2 weeks ago, he became completely bedbound, which was the final breaking point for his wife, who had tried desperately to be able to care for him at home. He's now a patient in an inpatient hospice setting. This evening he's visited by his entire family. The evening nurse is moved by this kind man. She finds herself touched by his gentle manner and his overt expressions of love for his family. His hospice room is covered with family portraits, albums filled with family vacation photos, cards made by his grandchildren, and several books on Judaism. Before the family leaves for the evening, they join hands and surround the bed, praying together that God will be with him through the night and offering thanks for their blessing of family. After the family goes home, the nurse returns to Mr. Farber's room, but she feels intuitively that there's something he's concerned about that may be preventing him from being at peace. She begins to talk with him and comment on his wonderful family, but Mr. Farber becomes very quiet, so the nurse sits quietly by the bedside. After a few moments of silence, tears come to Mr. Farber's eyes. The nurse asks, "Mr. Farber, is there something bothering you? Something I can help with?" His tears continue, and he says simply, "I am not a good man." The nurse is shocked by this contrast between his words and her image of this gentle, loving father, spouse, and grandfather. And he repeats over and over again, "I am not a good man. I am not a good man." He then tells the nurse about how he had an argument with a brother over 30 years ago, and now, despite his brother's pleas, every year his brother would call and leave a message on his recorder around holy days and ask to reconcile. Mr. Farber then openly sobs, telling the nurse how sorry he is that he never forgave his brother, that he has so few hours remaining and he does not have the energy now, but he hopes that his brother can forgive him after his death. This story raises important issues that we see so often with people who are seriously ill and suffering, and that is the need for forgiveness. A few years ago, I did a study where I collected about 130 stories, narratives from nurses who shared their experiences. The question that I ask of them is, can you tell me about a time that you were at the bedside, you were with a patient who expressed issues of regret or a need for forgiveness? And so nurses told these beautiful stories, amazing, heartbreaking stories. Many of the stories were veterans who, as their lives were coming to an end, said, you know, I killed someone in Vietnam. I killed someone. I never told anyone about this. I never even told my spouse. And now I need to tell you. And so they would confess to the nurse about things that had happened. So nurses told these amazing stories about patients' regrets, deep regrets, and issues of forgiveness. But then I asked the nurses, and how did you respond? Anyone want to guess what you think the nurses did? Listen, yeah, listen. That would be good. That would be good. Anything? Offered forgiveness, like I forgive you, right? Yeah. You are forgiven, right? Well, actually what happened is most of the nurses immediately wanted to fix everything, right? So when the patient said, I haven't spoken to my brother in 30 years, the nurse jumped up, ran to the phone and said, okay, we'll call your brother, you'll say you're sorry, he'll say it's okay, done, right? Right? 30 years of agony just shared, and the nurse wanted to fix it in 30 seconds or less, right? And yet what do we really know? What we really know is what the patient needed most was for someone to listen to their story, right? And to know that most of these things will not be easily fixed. So issues of forgiveness. There's a wonderful author, Ashby, who wrote about forgiveness and said, forgiveness moves beyond simple acts of pardoning, excusing, forgetting, or denying. The next story I want to share with you is one that was quite profound in my experience, and it was a story of a woman with pulmonary disease. Lucy Gutierrez is this 40-year-old homeless patient with severe pulmonary disease. She reported that she had no living relatives. Her symptoms were controlled, but she was aware that she would likely die in a matter of weeks. As the hospital social worker struggled to find a place for Lucy to live, given her multiple symptoms and complex medications, she told Lucy that there was no other choice, but they finally had found a county nursing home that had agreed to take her in. And Lucy panicked. She's 40 years old, and she said, no, absolutely, I can't go there. So at that point, Lucy then admitted to the social worker that she had lied, that in fact she did have living relatives, and that in fact that she had an elderly mother who she thought still lived nearby. They had not spoken in over 10 years. Their relationship was destroyed because of Lucy's drug addictions. Lucy also admitted to having stolen money from her mother and then admitted to physically abusing her mother during the worst times of her life. Lucy said that she could not possibly call her mother, but she did agree to let the social worker make the call. Her mother, without hesitation, agreed to take her in for the final weeks of her life. The hospice program assisted in the transfer home and offered some extra support given the dynamics of the patient and the mother. Lucy did remarkably well once discharged to her mother's home, with the exception that her pain could not be controlled. Her nausea and depression were much improved. She enjoyed eating her mother's cooking, sleeping in a soft bed. Until the last few days of her life, she tried to be independent, wanting to be as little burden as possible. The hospice had been able to meet Lucy's mother's request for a home health aide to help with her bathing, and Lucy and her mother did not discuss the past and actually spoke very little, but they spent considerable time just sitting quietly together. Frustrated by their inability to manage her pain, the hospice physician and nurses made numerous changes to her pain medication. In the weekly team meeting, the professional staff were discussing the various drug options that remained. About then, a home health aide interrupted to share her observation. While she was there giving baths, she had noticed that while Lucy took all of her own medication, she relied on her mother to give her her pain medication. The aide further shared that Lucy only takes her pain medicine if it's offered by her mother, and that she relied on her mother to decide what dose she should get. And so the team recognized this intense dynamic of this prodigal daughter, that Lucy was asking for permission from her mother in the form of pain medication. And so grateful we are to have nursing assistants and all of the people that interact with our patients who are very ill. One last case I wanted to share with you was in the area of renal disease. Marvin Wilson was a 62-year-old African-American man who went through a bitter divorce 3 years ago. Marvin and his ex-wife Gail had not been speaking since their separation. Both fought bitterly in dividing their property, and their 2 adult daughters became enemies as each took sides of one parent. These past 3 years included hostile interactions, court appearances, restraining orders, and even police visits. Both Marvin and Gail have since remarried. Marvin has end-stage renal disease, and he now is admitted to the hospital in the ICU, comatose and ventilator dependent. After extensive deliberation and consultation, a decision is made to discontinue his life support and allow him to die. In the first week of his hospitalization, the daughters argued angrily, and hospital security was called on 3 occasions. Since then, as the reality of their father's prognosis has sunken in and exhaustion replaced hostility, the family members have remained separated but more peaceful. The families have declined any chaplaincy involvement. Marvin had no prior religious affiliation, and when interviewed, Marvin's new wife said that she used to believe in God, but there could not possibly be a God if a man as good as Marvin is allowed to die like this. All of the extended family and the daughters and their spouses asked to be present as Marvin's life support is discontinued. A joint decision is made about a funeral home, but the nurse is aware that the families are planning 2 separate funeral services. Recognizing the impact and the power of stopping the ventilator and Marvin's subsequent death, the nurse is also aware of the absence of any ritual, prayer, or other sacred acts. On this, the entire family seems to agree. After he dies, the nurse notices that the daughters linger behind. She asks if they would like to stay and help her bathe and dress Marvin before the mortuary comes. In absolute silence, but constant tears, each daughter takes the side of his body, guided gently by the instruction of the nurse, as their father's body is cleaned and prepared. Again, that is the picture of care in response to suffering. One of my favorite authors, when I began to explore more in depth about ethics, was a beautiful book called The Female Face of God at Auschwitz. And it is written by Melissa Raphael, and she tells about the story of the Holocaust, but from the view of women. And she wrote about the care of women caring for other women in Auschwitz. And one of the things that she talks about is that in this circumstance where these other female prisoners, there was nothing they had no medication, they had no treatments, there was nothing they could do, but they still became the quote nurses because their charge was to really support and comfort the person who was dying. And I found that really, quite a profound reflection of that we are often so busy giving medications and doing treatments and charting and so busy with our tasks that we forget that it is, we who are the ability to relieve the suffering of the people that we serve. I lead an international and national education program for nurses called ELNEC, the End of Life Nursing Education Consortium. And through the ELNEC project, we train nurses and other professionals in how to care for people who are at the end of life. And one of the groups of nurses that we have worked with are critical care nurses. And how can we help these critical care nurses who are so busy with the technology and this notion of saving lives, how can we help them to shift to the idea of compassionately caring for people who are suffering at the end of life? We were doing one of our critical care nursing training courses, and I had given the nurses just a blank piece of paper, and at the top I had written one question. And the question was, what do you as a critical care nurse do to relieve suffering? It's the only question. What do you do to relieve suffering? So at the end of the day, when I gathered these surveys, one caught my eye, and I looked down because on this plain piece of paper underneath that one sentence, the nurse had written in big letters, probably about 2 inches high, "I show up." And then under that, this was what she wrote. "Sometimes we can only witness. We cannot fix or do the work of creating meaning. This family responds to support, to ideas, to reframing, but ultimately they have to wrestle with the guilt themselves. We can provide a container, a holding environment of safety so they don't have to do this in isolation. We can keep showing up even when it's messy and ragged and uncomfortable. And again, just to sort of share from the pediatric perspective, this is a beautiful book written by a father whose son had died. He said, "Death is awful, demonic. If you think your task as comforter is to tell me that really, all things considered, it's not so bad. You do not sit with me in my grief, but place yourself off in the distance, away from me. Over there, you are of no help. What I need to hear from you is that you recognize how painful it is. I need to hear from you that you are with me in my desperation. To comfort me, you have to come close. Come sit beside me on my mourning bench." I want to just sort of pull our time together by sharing with you sort of the 10 tenets of suffering that my colleague Nessa Coyle and I created in writing about the nature of suffering and the goals of nursing. And as I just go through these 10 slides, what I just invite each of you to do is for each of these tenets to just pause in your own mind and try to put a face on these words. Try to think of someone that you have known, heard about, cared for, who you think represents perhaps this aspect of suffering. The first tenet of suffering is that suffering is described as a loss of control, which creates insecurity. Suffering people often feel helpless and trapped, unable to escape their circumstances. In most instances, suffering is associated with loss. The loss may be of a relationship or of some aspect of the self, or loss of some aspect of the physical body. The loss may be evident only in the mind of the sufferer, but it nonetheless leaves a person diminished and with a sense of brokenness. Suffering is an intensely personal experience. Suffering is accompanied by a range of intense emotions, including sadness, anguish, fear, abandonment, despair, and a myriad of other emotions. Suffering can be deeply linked to a recognition of one's own mortality. When threatened by serious illness, people may fear the end of life. Conversely, for others, living with serious illness may result in a yearning for death. Suffering often involves asking the question, why? Illness or loss may be seen as untimely and undeserved. Suffering people frequently seek to find meaning and answers for that which is unknowable. Suffering is often associated with separation from the world. Individuals may express intense loneliness and yearn for connection with others, while also feeling intense distress about dependency on others. Suffering is often accompanied by spiritual distress. Regardless of religious affiliation, individuals experiencing illness may feel a sense of hopelessness. When life is threatened, there may be a self-evaluation of what has been lived and what remains undone. Becoming weak and vulnerable and facing mortality may cause one to reevaluate his or her relationship with a higher being. Suffering is not synonymous with pain, but is closely associated with it. Physical pain is closely related to psychological, social, and spiritual distress. Pain which persists without meaning becomes suffering. Suffering occurs when an individual feels voiceless. This may occur when the person is mute to give words to their experience, or when their screams are unheard. I want to conclude with a very brief excerpt from a paper that I read in 1988. So 30 years ago, and yet these words have stayed with me for these 30 years. They were written by a young physician. His name is Greg Sachs, and Greg was at the time a trainee. He was a medical resident, and he was working in a big hospital. He was on call for the night for internal medicine, and in the middle of the night, an older woman was transferred from a nursing home and admitted to the hospital. And so as the physician on call, in the middle of the night, he was asked to come and do the admitting history and physical of this patient who came in from the nursing home. So Greg wrote an essay that was published in JAMA as a medical resident, and he called it On Deeper Reflection. And what he talks about is how he came to this, awakened from the night and from his sleeping room. He came to the unit where the patient had been admitted. The nurses told him, here's this woman from this nursing home. Can you go in and, do the physical exam and, write some orders for us? And Greg went in and he began to do his physical exam of this older, very debilitated woman who had fallen and had now a fractured hip and was laying in this bed. And as he began to examine her, and as he turned her on her side and he began to examine, he noticed that there was this huge pressure ulcer, a huge decubitus had formed. And so he began to look at this decubitus, and he saw movement within the wound. And so he panicked, and his thought was maggots. There was something, in this wound. And so then the essay is he writes what's happened as he looked deep into this wound. He said, I saw no organisms. The wound looked clean, and there was a strange clearness in the center of the crater. I took a deep breath and looked again at the ulcer. Again, I noted movement within the sore. But this time, the movement paralleled my own motions. I moved closer and peered deeper into the cavity. Right in the center, in the deepest portion of the wound, I saw my own reflection staring back at me. And what he was seeing was that this woman had previously had hip surgery and had a hip prosthesis. So he was seeing his face within this metal prosthesis in her hip. But this is what he taught us. This is what he said. Seeing oneself in a pressure sore is a stark and frightening vision, disturbing on many levels. In addition to the grotesque wound and personal reflection, it seemed to mirror the topsy-turvy medical care given to many such patients. Mrs. Smith came from a hospital where she received mechanical ventilation for a respiratory arrest suffered when she was hypoglycemic. Yet she lay long enough without being turned for all the tissue between her skin and bones to necrotize. It is sad that somewhere in the course of a dementing process, Mrs. Smith lost many of the characteristics that most of us associate with meaningful adult human life. But it is sadder still that she received medical treatment that forgot about her as a human being. It is fitting to have seen myself literally within Mrs. Smith, and now to carry a vivid memory of her within me. It is a sharp reminder that I am always inside patients like Mrs. Smith, and that they are always inside of me. All of us are a part of the human community, no matter how demented, contracted, or incontinent. Debilitated and dependent patients need us to reach out and care for them most when we are starting to push them away. It is our distancing of ourselves from these people that is the true dehumanizing act. And so I hope that as you think about all of these wonderful things about your program, that you are reminded you are the therapy, right? You have this great opportunity to be close, to move close to the people that you serve, and in so many ways that we have the opportunity to relieve suffering. Thank you very much.
Questions?
First of all, yeah, thank you for your wonderful talk. I really appreciate your words. So, I guess I'm just wondering, I'm a social worker, and with my clients, there's like times when I'm listening to them and they're telling their stories, and I start to tear up and have that reaction, and then there's other times when like I don't, for whatever reason. And I know there are like studies and practices to like build empathy, but then sometimes I feel like engaging in that process is kind of a distraction away from being with the person. So I don't know if you had any thoughts about that, about being close in that way. Yeah.
Right. So I've been a nurse for 42 years. All of my time, has been spent in this world. So first, congratulations. You have ahead the most meaningful life work imaginable. Full of joy and full of the ability to relieve suffering. When I was very first starting my first job in oncology, somebody said, well, just don't be the first to cry, right? And so I always remember that it's probably good I kind of hold it together, and that I do have that awareness that, okay, he's the patient, or she's the spouse. I am here, in a therapeutic role. That said, there's lots of times I've cried, right? And I think that there is a very thin line there. I think there are times when shedding a tear, or really becoming very moved by what you're witnessing, is the most authentic, genuine expression that I hear. I hear your pain, right? I think over time, sort of you learn how to, what is the right thing to share when you are still with a patient or family. And I think what you really learn enormously is how important it is that you're surrounded by a group of colleagues, so that you can really, then leave this incredible, situation where someone is losing someone they love, but at least you have a colleague that you can go back to, and that's when you close the door and really cry, right? And that you're doing lots of things to nurture yourself, because, that grief that you experience is cumulative, right? It can just weigh on you and weigh on you. So I'm a huge proponent of how important self-care is. But I think, there are times when we cry. And I think, be honest. Like, there are times when people have said things to me that I've learned the most important thing I can say is just to say, could I just start by first thanking you for sharing this really deep part of your life, but can I also just say, I'm kind of overwhelmed. I'm just so, how could it possibly be otherwise that losing your grandfather, could not be so difficult? So I try to just come from a place of honesty and genuineness, and try to really nurture support so you can continue to do this work. The day you don't worry about these things is the day you need to resign, right?
Thank you so much for that talk. It was really great. I had a question about, you posed fatigue as a spiritual problem. Do you also see that as having a spiritual solution, potentially?
Sure, absolutely, because first of all, I would avoid solution, because it sort of goes back to, that we don't fix much, right? That we don't solve a lot. But what I would say is that experiences of fatigue or nausea, or many things that we might think of as purely physical, have deep psychological and spiritual meanings. So going back to the woman with ovarian cancer who was telling me, and she was actually kind of hostile that day. She was mad at the world that as the soccer mom now has ovarian cancer. She was mad that she wasn't going to get to see her boys grow up. She was mad that she was not going to be able to take care of her parents. So I have no doubt that how she experiences fatigue for the rest of her illness and the time of her death is profoundly influenced by what that fatigue means and the deep existential meaning, right? Because if she can't even brush her teeth, then, she can't make lunch for her boys, right? Then that begins to mean she can't be a mother, right? In her mind, she can no longer be a mother. And there's a deep suffering associated with, I can no longer be a mother. And so, as we do all the things we normally do to help people with fatigue, maybe there's a few medications we could try. Maybe we can bring in OT that can help with energy conservation, etc. Then what I would say to you is that we better be getting the chaplain in there too, right? Or we, all of us as clinicians, best be also thinking about the existential crisis of her fatigue, because this woman needs us to be there to hear, to listen to her say what it feels like to abandon her parents, because she won't be there to care for them. So I wouldn't say that we, that spiritual solutions. What I would say it is that whole person care that will respect that this woman has more than a physical problem, right? And spiritual care is a very important part of her fatigue.
Okay, we have to move on to stay on schedule.
Thank
Thank you
you.
so much.